Good evening and hello everyone. It is a great pleasure to welcome you to the CVI webinar on left main and bifurcation lesions, Road to Success for Percutaneous Coronary Intervention. We are delighted to have an outstanding faculty tonight to share various scenarios about doing bifurcation and left mains, starting with Dr. Lorenzo Azzalini, followed by Dr. Allison Hall, then Dr. Wissam Jaber, and Dr. Basem Elbarouni. There is CME for this webinar, so just go to cvinnovations.org and you can claim CME for this participation in this webinar. A few words for our faculty. Dr. Azzalini is currently the director of the Complex Coronary Intervention at VCU Health in Richmond, Virginia. Then Dr. Elbarouni is an associate professor at the University of Manitoba. Dr. Allison Hall is an interventional cardiologist at the Memorial University of Newfoundland in Canada. And Dr. Jaber is a director of the Cath Lab at Emory University in Atlanta, Georgia. Also to remind you that there are previous webinars at cvinnovations.org that are archived, and then also that there are also CME that you can go to cvinnovations.org. So without further delay, I will go to our first speaker, which is Dr. Azzalini, who will talk to us about provisional, which is kind of the starting point of all discussions on bifurcation. So Lorenzo, thanks again for being here tonight and looking forward to your presentation. And please, any questions from the audience or from the faculty, it will be great to share it in a very informal and interactive way.
Thank you, Manos, and everybody. Can you see my screen?
Yes.
Perfect. So in the next few minutes, I'm going to convince you that provisional stenting is the way to go for most bifurcation lesions, including true bifurcations. So why some bifurcations true bifurcation lesion can be treated with a provisional stent strategy like this one, while some others require a two-stent approach. Truth is that the MEDINA classification has its own limitations. Although it has widely been adopted due to its simplicity, it does not take into consideration any key features of side branch involvement, which should dictate stent strategy. So for this reason, we should rather be talking about simple versus complex bifurcation. How do we decide if a bifurcation is simple or complex? So if we take the definition study criteria for complex bifurcation, a key feature inside is side branch lesion length greater than 10 millimeters, plus some additional complexity criteria like calcification and thrombus. So if we go back to our first case, we'll see that none of these criteria are met, and the bifurcation is in fact simple. However, the second case was indeed a complex bifurcation, and for that reason, it was treated with a two-stent approach. How frequent are such complexity features? In the definition study, which included only true bifurcation lesions according to the MEDINA classifications, only 1/3 had a side branch lesion length greater than 10 millimeters. And as a result, at most 1/3 of true bifurcations can actually be considered complex. In the Excel trial, only 1/3 of left main stenosis greater than 50% were actually true bifurcation lesions. So if we crunch the number, we get that only barely 1/10 of left main stenosis are complex. So that all that you've been hearing about fancy two-stent techniques for left main PCI really only affect a small minority of cases. No matter how you treat them, complex bifurcations do worse with PCI than simple bifurcations. And in simple bifurcations, provisional stenting provides just similar results to stent techniques. However, in complex bifurcation lesions, a two-stent approach might be better. And I said might because in the definition study, statistical significance was not reached for this subgroup. So what have we learned so far? Most bifurcations, including the left main, are non-true bifurcation lesions that are simple. Complex bifurcation that are treated with PCI do worse than simple bifurcation. Provisional stenting is a standard for simple bifurcation. In a minority of cases, so true complex bifurcation lesion, a two-stent strategy might be better. Multiple studies have shown that in true non-left main bifurcations, a one-stent technique is superior to two-stent techniques. And as a result, 15 consecutive consensus documents from the European Bifurcation Club have endorsed provisional stenting as the gold standard for bifurcation PCI. However, this was challenged in 2017 by the DK Crush 5 trial, which demonstrated superiority of DK Crush over provisional in true left main bifurcation lesion, being associated with lower TLR, MI, and even stent thrombosis. And this was confirmed in both complex and simple left main lesions. As a result, the ESC guidelines in 2018 stated that Provisional, started providing a cautious, so a 2B recommendation for the DK crush technique for distal left main PCI. However, the DK Crush 5 trial was criticized due to several limitations, which include the fact that POT was not recommended by protocol in the provisional arm. Almost half of the provisional cases randomized to provisional had crossover to 2 stents. Final kissing balloon was performed in almost all DK Crush patients, but not in all of provisional patients, considering also that half crossed over to 2 stent strategies. Stent thrombosis rate was abnormally very high, 2.5% in provisional group, and most of the events happened actually at the time of systematic angiographic reevaluations. So as a consequence, it is not surprising that DK crush has not been widely adopted as the go-to technique for true bifurcation lesions. It is in fact technically demanding. Most of its supporting evidence comes from a small group of expert operators, and patient randomized to provisional did remarkably and unexpectedly poorly. Moreover, the EBC main trial, very similar in design to DK Crush 5, so it compared provisional versus any 2 stent strategy, in this case mostly culotte, 53% of cases, and this trial showed no differences between groups with regard to 1-year clinical endpoints, and as a consequence, the investigators recommended to continue considering provisional as the gold standard for distal left main PCI. There are some key differences between the 2 trials, but I want you just to focus on the 2 most important ones in red. So side branch lesion length was much longer in DK Crush 5 compared to EBC main, 16 versus 7 millimeter, and crossover to 2 stent strategy was extremely common, almost 50% in the provisional arm of DK Crush 5 versus only 22% in EBC main. So bottom line is here that we're really talking about 2 different patient population and groups of operators here. So let's review some case examples. So the first case is a distal left main bifurcation MEDINA 111 with a lot of calcium, but just focal involvement of the ostial circumflex and LAD. So in this case, we do rotational atherectomy from the left main to the LAD. We predilate both branches, as you can see here. We put 1 stent from the left main into the LAD, and then we do POT and kissing balloon inflation. And this is the final result, which is pretty good. And this again was a true bifurcation lesion. Second case is an 8-year-old woman with inferior ischemia and RCA CTO, pretty complex. And you can see here there is a focal involvement of both branches at the bifurcation and severe calcification just proximal to the crux. So we recanalize this with antegrade wiring. We reach the true lumen of the PDA. We do rotational atherectomy. Then we do kissing balloon inflation at the crux. We predilate the whole vessel, and we stent from the PLB all the way up to the ostium, and we post-dilate. And this is the nice final result with absolutely no compromise of the side branch, in this case, the PDA. Third case.
So Lorenzo, if I can ask you a quick question, maybe. So the case looks great, and here in this case, obviously things worked out great. But like in the last case you showed, what would you have done? Let's say that you lost the PDA, and then you had dissection, right, potentially, and the crossing. Then what would you have done? Would that be a very difficult, potentially thing to do?
So that's an excellent point. And actually, my last case will be about this scenario. So in this case, it's always possible to do a bailout to stent strategy. Depending on the angle, you can do, if the angle is narrow, you can do a culotte on an internal crush. If the angle is close to 90 degrees, you can do a tap, okay? And you can.
And I didn't see, did you gel a wire as well? Will you gel wire in these branches, or what is your recommendation on those?
So for sure, when the stakes are so high, like in a CTO with a lot of calcium, after doing Rota, we wire both branches. So you always keep at least track where the true lumen of the vessel, the side branch, the PDA is. And then if needed, you recross and kiss. I will provide at the end my algorithm for provisional.
Okay, perfect.
But thanks, very pertinent comments, and you read my mind actually. So what if we get more sophisticated? So this is a left main, distal left main into circumflex. This is so 101. But if we do IFR on both branches, the LAD is negative. So while the circumflex is positive, frankly positive. So physiologically, we can say that just the circumflex is the problem here. Accordingly, we predilate and put a stent from the left main into the circumflex. We jail the pressure wire into the LAD. We do pot, and then we shoot the final picture, which looks pretty nice. There may be some ostial pinching here. And in fact, with the jailed pressure wire, we detect that this is 0.83, which is positive. So angiographically intermediate, but physiologically significant. So we do kissing balloon inflation, and then we obtain a nice final result. Again, angiographically, it looks fine, but even more importantly, also physiologically, we restore optimal perfusion of the big LAD territory. And this technique has been published recently, and it allows to decrease significantly the need to go for a two-stent strategy. And so in this case, it was angiographically intermediate and physiologically positive, but many times it's the other way around. So the physiology is negative, even if it looks not so nice angiographically. And you can really decrease your two-stent strategies here as bailout. Let's see the fourth case. So
maybe one second there, maybe Lorenzo, maybe we can discuss a little bit with the panel, because that's actually a fascinating case. If you can go back one, just curious on the panel, how many people have jailed or like to jail pressure wires when you do a bifurcation? How many people want to have as the jailed wire a pressure wire?
I've done. I can talk here. Thanks, Manos, for this great session. I would be maybe uncomfortable, frankly, to jail the pressure wire just in case I lose it. I've done it once. If there's a lot of calcification, you're potting, I would kind of like prefer to people to have more experience in that, but I haven't done a lot.
Anyone else? I don't know, Allison or Basem, have you ever jailed the pressure wire? Or are you believers on this?
I have done it. Oh, sorry, go ahead.
Go ahead, Allison, sorry.
Okay, I have done it on rare occasions, but I must say I really like those case demonstrations just now from Lorenzo. I think I might consider doing it a bit more frequently. I'm comfortable with jailing some of the newer generation pressure wires, so that's definitely something that I might start to do a little bit more often, but it's certainly not something I've been doing routinely, I must admit.
And I agree, when there is calcification, I mean, these wires, at least most of them are not true workhorse wires. So I've had with at least one non-hyperemic pressure ratio wire, a fracture, not in a bifurcation, just in a calcified and tortuous vessel. So you got to be careful and maybe not use it like in each case. I agree with you.
And then there's the concept. Basem, how about your thoughts on jailing wires, pressure wires?
Yeah, I'd probably be with more in Wissam's camp, where I haven't usually tried it, and I do worry about the the wire durability. I generally have found with pressure wires that once I've done the pressure wiring, I would take it out because I'd like to do a pressure wiring at the end, even in not bifurcation lesions. And if I work over the pressure wire by the end, it's usually bent and it's not working as well.
So actually in this study, they did like a microscopy of all the wires. There was, mild, moderate, and severe grade of damage, but severe damage was just apparent in a very small minority of cases, but they never had any fracture. But it's just about like, maybe, I don't remember if it's 50 or 60 cases. So, it's not like a big registry. In fact, it's
and I think
Lorenzo, you can always rewire with the pressure wire, right? I mean, if we need it, you can, after you're done with the bifurcation intervention, just wire de novo with the pressure wire, maybe safer.
Yeah, you can do that. They're not as maneuverable sometimes, but yeah, you can always do that. So it's a new area of research and clinical exploration. So let me share with you the last case. So this is a case of a MEDINA 111 true but simple, again, bifurcation, because it's just focal on all, both on the main branch and the side branch. So predilatation with kissing of the two branches, and nice results so far. Provisional stenting, like most of us would have done probably. Maybe I'm biased, but pot. And after pot, there is a dissection of the D1 ostium. It's not flow limiting, but it really looks ugly. So in this case, we can dilate the ostium again and see if that is sealed, but it improved just very mildly, so it was still there. So the decision was made to bail ourselves out with a two-stent strategy. In this case, due to the angle, tap was not a good choice. You can do internal crush or pull out, and pull out was chosen here. pot kissing, and this is a very nice final result. So again, you always have bailout options, and it's not because you don't choose an upfront two-stent strategy that you're committed just to go provisional forever. So for just concluding, for the sake of time, I could not discuss about the role of imaging in bifurcation PCI. However, there are ample data, particularly for IVUS and Left Main PCI, showing that intravascular imaging is associated with a marked reduction in hard clinical endpoints on follow-up, including stent thrombosis. Summarizing, the MEDINA classification only tells parts of the story. We should rather be talking about simple versus complex bifurcation. Only a small minority, approximately 10% of true bifurcation lesions are complex, and those with side branch lesion length greater than 10 millimeters and additional complexity features, and only those should be treated with a two-stent strategy, preferentially DK crash. But the vast majority of bifurcation lesions should be tackled with a provisional approach, wiring both branches, pre-dilating the side branch, stenting the main branch, potting, and then considering, in some cases, physiology to evaluate the side branch stenosis significance, doing kissing balloon inflation and repot as appropriate and as guided by the angiography and physiology. And in case like the last one with flow limited dissection or residual positive physiology on the side branch, two-stent strategy like T, TAP, pull-out, and internal crush are always feasible. We should guide our procedure with imaging, ideally on both branches, both at baseline and at the end. And I will leave you with this visual summary. So an upfront two-stent strategy should be considered only for true bifurcation lesion with long side branch involvement greater than 10 millimeters. In all other scenarios, including true bifurcation with focal less than 10 millimeter side branch disease, a provisional approach is the way to go. Thank you very much.
Thank you. Thanks, Lorenzo. That was outstanding. And actually, related to your last case, maybe we can poll our panel today. So I know you pre-dilated both the main vessel and the side branch, right? And there is still some controversy on this, because what can happen sometimes, you may dissect the side branch. Now, in your case, it looks like it happened later on, but theoretically, it could have happened when you did the pre-dilatation. So curious, Basem, do you pre-dilate routinely the side branch if you plan provisional, or what is your strategy in general for those cases?
If I generally try to avoid pre-dilatation, because if you're trying for provisional, I think you're going to increase your chances of crossover. But on the other hand, I don't want to lose the side branch completely. And I think if there's a lot of osteal disease, pre-dilatation might reduce that with a higher chance of crossing over. So I think it's a case by case. I think in this type of anatomy, I probably would have pre-dilated first.
I tend not to pre-dilate, and if I want to pre-dilate, usually I go with a two-stent technique. I may be different. Obviously, I'm talking to people who are very experienced in bifurcation stenting, and we have each our own total preference. My preference is not to mess up with the side branch, and it doesn't mean I'm going to treat it. It doesn't mean I'm going to go with two stent technique. And many times we leave side, if it's not a big circ, I'm fine leaving a 90% stenosis there.
Perfect. Allison?
So I would say that I actually changed my practice somewhat. I think early on I used to dilate the side branch much more frequently if it looked significantly stenosed, but I did run into more troubles off and on with dissections that would commit me to a two-stent strategy. So if I've decided on a provisional technique up front now, I don't so much dilate the side branch anymore and deal with it afterwards if I have to.
It's interesting. The Euro Bifurcation Club recommends pre-dilating the side branch with undersized balloons gently. And there are some studies from the past showing that if you don't, in true bifurcation, if you don't pre-dilate, you're going to end up post-dilate, like dilating after. So that's why the European Bifurcation Clubs recommends considering pre-dilatation of the side branch. But it's a very hot topic, and thanks, Manos, for bringing that up, because there are wide variation in practices. You can also make an argument that you can dissect the side branch and then you're committed to a two-stent strategy.
Okay, and we've got a few questions. I'll go very quickly. I don't have to go to the next talk. But one question is, which crossover strategy would you advise between culotte and internal crush? I know you used culotte, Lorenzo. What is your thoughts about internal crush?
So it's interesting. It's not like crushing and then covering the crash like in regular mini crush or DK crash. So then you leave these crash struts that are somehow exposed. Nobody really knows, because it's what's going to happen. There are not many cases done like that. It's been described as feasible. That's why maybe I tend to use culotte more
Sure.
But yeah, it's all type C recommendation.
Sure. Allison, what is your preference for culotte versus internal crush if you have the scenario that Lorenzo had?
I would tend to use a culotte, and I think in general with bifurcation, when you get into either a converted to stent strategy from provisional or upfront to stent, it is important to go with a technique that you're comfortable with as well. And for me, culotte would definitely be the one that I'm more comfortable with in that scenario. So I'd probably default to that. And really, I like to do tap most times unless the angle is not favorable for that.
Perfect. So actually, that's quite, I think most people would usually say that tap would be the number one. I think most studies people do more tap, but I think culotte might be preferable to internal crush, as you said. Another question, maybe Wissam can take that. It's two-stent technique, use DK crush, and this is for provisional, use a drug-coated balloon. And I don't know, and obviously in the US we don't have them, but what are your thoughts? And actually maybe I should send it also to Basem, who probably have access to drug-coated balloons, and Allison.
It's a question for, you're right. We don't have experience with that. I guess it depends on the size of the vessel. If we're talking about smaller vessels like a diagonal that Lorenzo has shown, I don't have any problem choosing in the future drug-coated balloons for these type of lesions. I'm not sure how I would think about a big dominant or co-dominant circumflex that I'm treating in a distal left main. Maybe I would choose something different. I would definitely go with a stent there.
I have definitely used drug-coated balloons in smaller side branches. The only thing I will say is that while I like the drug-coated balloons in multiple scenarios, you have to be careful. They can cause dissections pretty readily, is my experience with them. So you do have to be a little bit cautious with your inflation pressures and your sizing and your placement and what have you, but they can be a good option.
Perfect. And then I think we have to go to the next presentation. But for a last one, and maybe Basem, we can address this. Actually, or Lorenzo, there's a question about thoughts on nano crash, which I know Lorenzo, by the way, Lorenzo has a beautiful paper in your intervention just published, the beautiful history of the two-stent technique with excellent illustrations. So I think nano crash, you addressed it very nice, Lorenzo. So what? Any thoughts? 30-second thoughts on nano crash?
So at some point, this nano, mini, it's a bit of semantics. So there are slight differences, and there is too, granular. We will need more time, and I advise you to read these reviews that Manos is talking about. Also, Manos mentioned some. He wrote a DK crush troubleshooting review in your intervention. So I think that the key thing of all this nano crush philosophy is to minimize the amount of metal in the side branch ostium, because originally the original crush by Colombo was up to 5 millimeters, which is really too much and created a lot of problem for recrossing, for kissing. And if you don't kiss, then there is a higher likelihood of restenosis or even thrombosis. So I think that the nano crush philosophy is just making your life easier to reaccess the side branch for final kissing balloon, and that's its value. But beyond the semantics, many people just call in mini crush other nano crush to differentiate themselves, but it's more or less similar.
Perfect. Well, again, due to time, we'll go on to Dr. Hall, who's going to talk about the topics. Actually published another beautiful paper in your intervention, which is about DK crush troubleshooting. Allison, thank you so much.
Okay, so thank you for inviting me to speak on DK crush troubleshooting. So in my mind, there are 4 key principles for having a successful DK crush case, essentially. So first of all, preparation is key. So as you may know, of course, the DK crush is almost like a recipe of sorts. There are multiple steps involved with it, and you need to be familiar with each. Importantly, to be familiar with the kinds of challenges that can come up at the various stages of the intervention. So that's absolutely key. Secondly, practice is very important. So the more experience you get with this technique, the more success you're going to have with it, and the less frustration. So ideally, of course, you want to be using this technique initially in controlled settings, like planned upfront two-stent strategies in elective cases, as opposed to doing your first DK crush in a crashing, left main patient at night. Patience is absolutely a virtue when it comes to the DK crush. So this is definitely not a wham bam done kind of technique. There really are multiple steps involved, and you have to be ready to face the different challenges that can come up. And relatedly, persistence is important. So I will be going over some of the tips and tricks that can get you out of the challenges associated with the technique. And generally, if you apply those in an algorithmic fashion, you will have success. You just have to be patient and persistent. So generally, there's two main types of challenges that I see as you go through the steps of the DK crush. So one surrounds difficulties wiring, and the other surrounds difficulties advancing equipment. So here are the steps of the DK crush, which I won't go through at this moment, but I do want to highlight what I think are more so the painful steps of the technique. So things first start to get challenging when you have to rewire through the crushed side branch stent initially. That's not so bad, but that can be tricky at times. Then getting the balloon over that wire can sometimes be challenging. And more importantly, once you actually have the main vessel stent also in place, rewiring through that as well as the crushed side branch stent, and then getting your balloon into the side branch, I think that latter step is by far the worst spot where I tend to get stuck from time to time. So in terms of difficulties with wiring, again, you encounter this at several potential stages of the DK crush. It can happen even just early on when you're trying to wire the main vessel and the side branch. Again, it can happen as you're trying to rewire the crushed, rewire the side branch through the crushed stent. It can happen certainly when you're trying to rewire through the 2 layers of stent into the side branch. And basically along the way, whenever this is occurring, there are 2 main ways that you can approach it. So there's wire-based solutions and microcatheter-based solutions. So in terms of the wire, easiest thing, I mean, you can put as a different kind of bend or a more pronounced bend on your wire and see if that helps you. Choosing a different kind of wire, something hydrophilic or with better torqueability may be advantageous. And then you can use dedicated techniques like a hairpin technique, which I'll review in a second, to try to get your side branch wired. For microcatheter-based approaches, of course, you can take just a standard microcatheter and use that to direct an angulated wire into the side branch. But you can also take pre-shaped microcatheters or flexible microcatheters to help you navigate the angulation. And then you can also take a dual lumen microcatheter, of course, to navigate into the side branch. And then importantly, if you're really having trouble wiring the side branch, once in a while, it may help to further modify the main vessel disease as well. And that may change things in a favorable fashion sometimes and allow your wire to pass. This is just a visual on some of those things that I mentioned essentially. So altering your angulation on the wire, of course, or choosing a different type of wire. Here you see a standard microcatheter that's been used to direct a wire with more of a bend on it into a side branch. Angulated microcatheters can be quite helpful, and also dual lumen microcatheters, as mentioned, with a wire in one port in the main vessel and then wiring into the side branch through the second lumen. The hairpin technique is worth reviewing. So basically, you take your wire and advance it out through the introducer, and you bend it back on itself with about a 180-degree fold. Then that V-shaped fold that you've created, you insert that directly into the TUI and push it down past the side branch in the vessel, and then gently pull it back. And in so doing, your hope is that that wire is going to prolapse into the angulated side branch and allow you to get in there successfully. And, you know, in a simpler sense, sometimes you can just umbrella, you know, kind of push a wire that's got a curvature on it downwards and pull it back as well. And sometimes that works. So when it comes to difficulty advancing equipment during the DK crush, again, several steps can have this challenge. So even initially, when you have to just balloon your main vessel and your side branch to prepare the lesions, when you have to get your stent into the side branch, and then, of course, as you go on to perform your kissing balloon inflations at various stages of the technique. So when you're encountering this challenge, there are multiple different techniques that can help you. And really, oftentimes, you have to use a combination of techniques. So one of the simplest things you can do that often works for me is if a balloon won't go, for instance, and I'm happy that I'm in an appropriate strut with my wire, and then I take a low profile balloon and For me in Canada at my center, that's oftentimes a sapphire balloon, and I've had excellent luck with that. And then usually if you're able to get that small balloon in, then you can subsequently pass larger balloons and serially dilate and get your equipment in. It goes without saying that adequate guide support is very important. So whether that's choosing a more appropriate guide, or importantly, using techniques to deep seat your guide liner or anchor balloon techniques, for instance, to get your equipment down. If you can't get a balloon in the side branch at all, then if a microcatheter will pass for you, then that may create enough space for you to get a balloon in subsequently, or you can use that microcatheter to exchange to a more supportive wire that may then allow equipment to pass. Of course, if you haven't stented yet and you just can't get equipment into your side branch, or of course your main vessel, then atherectomy or other plaque modification strategies might be necessary. So just again, to go through some of those techniques, this is one I didn't immediately mention on the other slide, but the one-handed technique is something that I find very valuable for equipment advancement. Securing the guide with your left hand, using your ring finger and your middle finger to hold the TUI and the guide wire, and then using your thumb and your index finger to advance the equipment. And I must admit, when I started learning this, I disliked it. I found it very cumbersome, and as I got used to it, I absolutely love it now. It really helps. Inchworming is my favorite way to advance guide extensions distally in a vessel, and I tend to have good success with it just with small balloons, although you can certainly use larger balloons and larger vessels. I often take even just a 2mm balloon and I stick part of it within the guide extension itself, inflate to about 6 to 8 atmospheres with a rapid deflation, and advance my guide extension. And almost always that allows me to deep seat my guide liner successfully, and in most cases safely. I think it's less traumatic for the vessel. The wiggle wire is also one of my last resort tricks that often gets me out of binds where I can't advance equipment. So you can see that it has these undulations proximal to the distal tip that help deflect your equipment away from whether it's the vessel wall, calcified segments, or tortuous segments, and it can allow you to advance your equipment. Ultra low profile balloons I already alluded to, but things like the sapphire, etc. And then the other thing that's important to remember is you may be having difficulty advancing equipment because you're in a suboptimal strut, location essentially. So intracoronary imaging can be helpful here to help you sort that out and select a better strut if possible. Now, that being said, sometimes it can be difficult to rewire that side branch at all, and sometimes you have to work with what you can get, but ideally you want to choose the appropriate strut. So some final tips and tricks for the DK crush. When you are deploying your side branch stent and you're about to crush it, make sure that you don't deploy that stent without having a balloon ready in the main vessel to crush it afterwards, or else you're not going to be able to get that balloon down, or you'll have a real struggle to do it afterwards. Also, before you crush that stent, make sure that you don't need to do any work distal to the side branch stent. For instance, if you created a distal edge dissection or something, it's better to treat that before you go ahead and crush the side branch stent. Jailing of wires comes up all the time with this technique, and personally, I'm not promoting jailing wires because obviously there's potential drawbacks if it gets stuck, but I personally find it quite acceptable to jail a wire, at least during the initial stent crushing phase. But once I go on to have the main vessel stent in place, I tend to remove the wire at that point and not jail it behind 2 layers of stent. It is actually quite acceptable to jail a polymer jacketed wire, and in small series it's suggested it may actually be superior to do that, which is contrary to what you sometimes hear from the past. So don't be too worried about that. It's always important to do the pot and repot steps, because otherwise you're going to be prone to wires going behind your stents and deformation essentially of your bifurcation and your stents. And in terms of the wire recrossings into the side branch with DK crush, generally for the first rewiring of the side branch, it's recommended to go through a proximal stent strut, whereas on the second recross to go through a distal stent strut. And there is a section on that in the paper that I published on DK crush troubleshooting that shows some images that are helpful for understanding that. So at the end of the day, the DK crush can be a very tedious technique, but with resourceful troubleshooting and practice, it certainly gets better. Keep in mind that despite doing all of this, yes, once in a while things fail and you can't complete, for instance, your final kissing balloon inflation. So again, it is important to choose your cases, selectively when you're going to go ahead and do this technique, and make sure that it's appropriate to proceed and that you think you'll have a reasonable chance of success. So thank you very much.
Thank you. Thanks, again. I think, as you said very nicely, that this can be a complex technique, but if you know what to do, if things don't work the way you anticipated, then that can come a long way. So maybe we start from Lorenzo. So Lorenzo, what wires do you like to use for rewiring? Do you use polymer wires, workhorse wires for DK crush, or otherwise rewire the side branch?
So very important question, Manos. So the same group that I show you the paper about the feasibility of jailing the pressure wire, they have this microscope, and this group in Cordoba, Manuel Pan and Soledad Ojeda, showed that actually what Allison just mentioned, that polymer jacketed wires get less damage than the non-polymer jacketed wires. So in general, I tend to use also for cost reason, like regular workhorse wires. I just try to use two wires that are different in color, like a run through and a B&W. But if I have any difficulty rewiring the side branch, I mostly go for a Sheon black, usually.
Perfect. Basem, how about you? If you have the wire through, but now you cannot get the equipment, the balloons and the stents through, what is your preferred technique from the things that Allison showed or otherwise?
Thanks. Yeah, I find the microcatheter technique seems to work the best, and I usually combine a microcatheter with increasing support with an anchor balloon. So if you've stented the main vessel, or you can always use an anchor balloon down there to keep your equipment in place, and then a microcatheter usually cross. And then once I've crossed with the microcatheter, I only have it across, so then I would exchange for the wiggle wire. Double whammy. I'm there. Don't want to save time. Get the wiggle wire down there, and then we're good to go.
Perfect. Thank you so much. And actually, Jason Walmuth is another operator who uses routinely for every bifurcation. You use a Corsair for recrossing exactly for the reasons you mentioned, and he has very good results from that. Wissam, any other thoughts regarding the troubles that you can encounter with DK crush?
Yeah, a couple of things I want to add to Allison's great talk. I agree with using polymer jacketed wires, maybe Whisper wire or Xeon black to re-enter. But if anything else, if everything else fails, I find the Miracle wire to be helpful in these cases. Miracle 6 could be not just for pushability, but also it gives you excellent support for balloons to get over it. So that would be one thing in my armamentarium. The other thing that Allison didn't mention is if gear is not getting back into the side crush stent, you can use the balloon in the main branch to anchor in the stent already placed in the main branch, and that can allow for excellent support to get back in. Also, as part of balloons, you mentioned the Sapphire balloon. In my experience, the Coro 1.5 balloon is one of the best profiles to cross when you're having a hard time crossing, and it would be my #1 choice in these cases. But I just want to comment on all these is that so many, all these techniques and issues and problems with DK crush troubleshooting tells you that we really don't know yet how to stent bifurcations, right? We have not really perfected bifurcation stenting.
Right. I guess in the meantime, we go with patience and persistence. I think these are great words of wisdom, because I think that's what I find myself all the time. Sometimes you do need a lot of patience for this. But let's move on to the next presentation. Actually, Dr. Jaber will present about left main and bifurcation, imaging, lesion preparation, and hemodynamic support.
All right, thanks a lot, Manos. This is a large topic. I'm going to focus on a few things that I feel are important to me. Disclosures. So there's no question that imaging is imperative in treating bifurcation and complex lesions in general. The question is whether you use IVUS or OCT is really personal preference. There's pluses and minuses for either. And I'm not going to go in details of about the difference in these techniques. One thing I want to add is if I'm treating left main, usually I would favor IVUS just because frequently you have to stent up to the ostium and you need to see that. Also going back and forth with into both branches, it could be cumbersome with OCT with contrast injection. So this is where IVUS has a little bit extra advantage on OCT. But a lot of information you gain from imaging. First you can document left main significance. Sometimes on angiography it looks bad, but when you go in to try to treat it, MLA is more than 6 and you can defer it. Sizing of vessels is important, obviously. Extent of disease, you know where the landing zones are. It also can tell you the tightness of osteal disease, so you can change your stenting strategy, like Lorenzo has kind of mentioned the provisional stenting. Many times I've changed that based on the IVUS showing that the ostium of the circumflex, for example, is not significantly diseased. Extent of calcium, you can tell on imaging, 360 degrees or 270 degrees, you want to prep this lesion with atherectomy. Post-stenting important for need for further optimization, evaluation of stent edges. And really, if you use an IVUS, you use less contrast. You don't need to take a picture every time you place a stent. It's interesting that despite all this, the use of IVUS is not really high. And in the DK Crush 5 trial, for example, the use was only 40%. Now, there's a lot of trials. I'm not going to go, a lot of studies, I would say, not randomized trials, but I don't want to go into details on all these, but just a couple examples. Noble sub-study showing use of IVUS versus angiography, a significantly less risk of target lesion revascularization, mostly because of better stent expansion at the end of the procedure. And also the main compare registry looked at angiography versus IVUS guidance, showing less mortality and less mortality MI with IVUS guided strategy for left main. There's always caveat for imaging, like everything we use, and I'm going to mention a few that I feel are important to me. There's always difficulty in accessing severe tortuosity and calcification, especially when you placed already the stents. Sometimes those IVUS can get caught at the edge of the stent, deform it. So yeah, you have to be careful as pushing these hard, not getting caught, and occasionally you may not be able to image at all. There's also, we still also don't know what the optimal final stenting results are when it comes to area. We kind of know from the post-Excel data that maybe 6 millimeters at least for the circ, 7 for the LAD, and 10 for the left main are the numbers you need to aim at. But obviously this is different based on how big the patient is, what the original size of the vessel is, dominant circ, etc., etc. The other thing is reference diameter can be hard to assess in left main, especially short left mains when they diffuse the disease. For example, here on the left, what is the size of this left main? Is it the yellow arrow or the blue arrow? It's really hard to tell. Sometimes you have to guess, go somewhere in between. Same thing on the right. Do you expand? Do you go just within when you have such a big vessel? I would say maybe average of these. If I'm taking the blue line, I would maybe oversize slightly, and I would undersize if I'm measuring with the yellow line from black to black, from media to media. The other thing that I want to cautious people about is oversizing and perforation. Remember, when you're IVUSing, especially in big left main, when you get close to the ostium, you assume that the IVUS is straight in the vessel, but actually it's tilted such that when you're taking a cross-sectional measurement, it's really an oval. And I would not take an average of that oval or the large line here. I would take the smaller diameter because that represents usually the size of the vessel. And be careful not to overdo it when you have significant calcification with a 1-to-1 sized IVUS, because something like this can happen. This is an unfortunate case of severe calcification in proximal left main. Appropriately sized balloon, but it's 1-to-1 in an old patient with high pressure can lead to this catastrophic result of left main perforation. How about support in left main PCI? I'm surprised as how much this is used and standardized with really lack of adequate data to support that. The only randomized trial we really have on that is Protect 2 trial that showed that Impella versus intra-aortic balloon pump for multi-vessel or left main disease did not have better outcome than compared to intra-aortic balloon pump. But though on per protocol analysis, there was some difference at 90 days, but this is only speculative data, and more data now we're awaiting from the Protect 4 trial. It was not hard to find a study published by Lorenzo Azzalini. So we have here a study that he's done on patients looking at Impella support versus no support retrospectively, and with propensity matching, there was no difference in outcome. So the bottom line is no solid evidence, but it doesn't mean you don't use it. It really has a room to use. But whatever we're going to come up with guidelines are really based on opinions and some sort of studies that are not randomized. My approach is usually to use in patients who already have cardiogenic shock that need support anyway in PCI. And also in complex bifurcation left main and need for atherectomy, especially if in both branches need atherectomy, and if ejection fraction is low, I would not do it for normal ejection fraction, even if atherectomy is needed. And maybe for less complex left main interventions in the presence of decompensated heart failure. So if you have high EDP, low cardiac output, and low blood pressure, these patients tend to not do well as soon as you touch the coronaries, and you really want support to be able to go ahead with the case. I would personally avoid alternative access. We see a lot of transcable and axillary done for these, but you're adding another layer of complexity and complications for a device that does not have a strong mortality advantage, at least in studies. Now, how about lesion preparation? Very little data. Obviously, we fought earlier about what to do inside branches, how to prepare them, and there's no answer to this. I would say it's imaging guided. I would use rotational orbital atherectomy if I have significant calcification. Bifurcation lesions, very important to prep them well, so be able to do all the techniques and the tips that Allison mentioned. Lithotripsy, I've really found it helpful, especially in low ejection fraction, especially when you have diffuse disease. In these patients, I'm tending to use shockwave balloon lithotripsy as a first-line treatment instead of atherectomy to avoid myocardial dysfunction and kind of damage from atherectomy. Although I've been less impressed with the results of the shockwave balloon in osteal and heavy deep calcium disease, it's not as good as when you're treating mid lesions. NC balloons and calcified lesions are important. You really want to prep these vessels well. And I personally do not prep the side branch unless I intend to stent, and I know that this is controversial, like we discussed before. This is an example here where we can discuss if you want. 79-year-old patient with cabbage, came with ACS, ejection fraction 55%, all grafts occluded, RCA occluded. Here we have severe left main disease. In my mind, this is severely calcified. I'm going to prep this lesion with atherectomy, at least in the LAD. The circ might or might not be severely diseased. We can assess that with ultrasound. But I personally would use atherectomy, and I would not use support in such a case. Anybody would use support in normal ejection fraction?
Do you have a feeling pressure? Is it a wedge pressure by any chance, or?
His wedge pressure was 18.
Okay.
And I made that up. I just want to see what you think.
Good job. Lorenzo, go ahead.
Yeah. So I often had these cases, and we've had surprises. So this is pretty calcified left main. Even with a normal LVF, I've had patients with abnormal right arc cath, not necessarily the filling pressures, but even subclinically low cardiac output and index, despite normal filling pressures. And then sometimes you get surprises. So if you decide to go for the Impella, you see like some decrease in pulse pressure and even a flat lining sometimes, especially on the left main. But I agree with Wissam. There's now solid data until Protect 4 is out. So I think it's this is how I do it. This is how you do it. And in many cases, there is a significant overlap where both strategies could be good for the patient.
Any other thoughts, Allison or Basem?
Yeah, I think personally, I would probably want to use support. I mean, Lorenzo does point about the issue about loss of flatlining, although I wonder how much that is true physiologic or it's just the Impella taking over and keeping the alveolo. But in this type of lesion where there's heavy calcification, where I want to take my time making sure I get good expansion, good results with atherectomy, I'd like some form of support. I might just go with a balloon pump. The Impella is great, but there does come with, it's a large bore axis that does come with risks of vascular complications, and not mentioning cost in a Canadian system, which is a huge issue. But my only concern here is if the patient starts to crump, I might have to rush through the procedure and not get the perfect result I was hoping for.
And also, I forgot sorry, Wissam, I really feel you in the case that you showed the perforation of the left main, because I had the very same case in a kissing balloon in a DK crush of the left main. With the Finney's formula, the two balloons were about 4.3. The diameter of the left main by IVUS was 4.9 on average, but probably, you know, I don't recall exactly, but the left main was eccentric. So had I, you know, had your presentation before that case, I might have avoided the perforation, unfortunately. Sometimes, you know, eccentricity of the vessel, especially in elderly patients, something to take particularly care of when you choose your balloon. So maybe next time, in such case, I will follow your advice, going with just being more conservative, using just the smaller of the two diameters.
Perfect. So maybe we can go on. So since because of time.
Yeah, so I'll go on here, and I realize there are different approaches, and in general, I'm not showing here what the right approach is. It's what my approach and our approach actually at Emory is to be more conservative, and this is somebody we rarely put any support. This is rotational atherectomy. Obviously, you only have one wire for the atherectomy. You're never going to use the side branch, lose the side branch by doing that. Then you're going to wire the branches that you need to wire. You want a balloon. On IVUS, you see that the ostial LAD, there's a lot of calcium, but it gave well, and you see the breaks in it. The ostia of the circ and the left main were not calcified. So this gives you an idea of what you need to do, but the circumflex had significant disease that needed stenting. That did not need any preparation. And then this is information you get by IVUS, size and everything. And it continued with detailed DK crush. I'm not going to go in details on technique now. You've heard about you heard about that with Allison, but you'll see here a stent being crushed in the circumflex, and then the usual rewiring initially, double kissing initially, and then kissing initially, and then rewiring again, and final kissing, and then you have a good result. The other thing that I found atherectomy, since we're talking about preparation, is helpful in atherectomy itself can help sometimes if you have severe calcification with a very hard takeoff of the side branch. If you do atherectomy in the main branch, you can modify it enough to be able to wire the side branch. This is a case that I had that was impossible to wire with a wire that was biased away from the vessel. And then after the atherectomy of the LAD, I was able to easily wire down the circumflex for the bifurcation work. On to this is my last case. So 88-year-old man came in with non-STEMI ejection fraction 25%, blood pressure really borderline 95/60. Kathy had severe disease. His EDP was 26. I know we discussed this before, but I think I would at least put support for this guy. This guy has all kind of features that tell me he's not going to do well. Coming with acute symptoms here, non-STEMI, low EF, borderline blood pressure, and high EDP. Clearly, support is indicated in my mind, unless anybody else thinks differently. Initially ballooning the circ and LAD, I like usually to avoid doing atherectomy up front on these patients because they have very little reserve. And even with support with Impella, I've seen these patients not do very well for a while afterwards because the initial injury that happens with atherectomy could last for a while. So after ballooning, I was both segments, but unfortunately both, here I have one image kind of trying to be cheap that both shows both the openings that are circumferentially calcified. Decided to go, as I'm doing with these patients that are pretty high risk with IVL, with lithotripsy balloon here, both on the circumflex and the LAD sized 1:1. And you can see it here initially was not given, and here it gave easily. Did the same thing on the LAD. And then
you have hemodynamic compromise. How long do you do? How many pulses do you give at a time? You give 10 pulses and get a break, so you get less ischemia.
This is where the Impella is helpful in these cases. Is that you can keep the balloon up in the left main for 10 seconds. I have not had any issues with keeping the balloon. I've done several lithotripsy on left mains and ostia of vessels, and I have not had much problems with patients tolerate it really well. And for these sick patients, I do support. And in patients that I really don't want to keep long on the table, I've been doing this technique. I'm not sure I want to advocate it necessarily. I've done it at least on 5 or 6 patients where It's kind of modified Szabo technique, but what I do is I pre-mount my culotte, one cell culotte. I lift one strut here, put the main branch wire, and then put the balloon side 1-to-1. This is the NC balloon that I'm ready to culotte with. And as the wire, both of them go together here, the balloon on the main wire and the stent on the side branch, and they just place themselves nicely on the bifurcation, and I'm ready to just culotte. I don't have to puff and see how much I'm protruding. I go ahead and inflate the stent and inflate the other balloon and kiss. So I've already done the initial rewiring, and I've never unwired any vessel. I've already kissed my first kiss, and both vessels are prepped. I then go ahead and stent the main branch, and then pot, and then the rewiring is easy in the culotte after you've potted and stented both branches, and then you do the kissing balloon. So this has worked nicely for me. The only caveat that I would say, you really have to prep the vessels well, because if you raise a strut, you don't want to take the stent out through the guide just in case it gets caught at the edge. Also, this is a technique for left main bifurcation, really not for distal bifurcations, because it's going to be hard to send this both balloon and stents together down all the way down in the vessel. This is far the result of this patient. So in summary, use of intravascular imaging in all bifurcations and left main are necessary for multiple reasons that I mentioned earlier. Adequate preparation with either atherectomy, IVL, and appropriate sizing of balloons is important, and support for low EF and complex left main bifurcation that requires atherectomy, especially with high filling pressures. Thank you very much, guys.
Thank you. Thanks, Wissam. I think it's great to learn the Jaber technique for doing left main bifurcation. So I think another moment, actually, I love it. Again, as you say, it may be a little tough to deliver it sometimes, but it looks like very reasonable. So look forward to trying it in the next case. But I like what you said, that if you do have a calcium and difficulty delivering, be careful, because the stent may not be coming out. So excellent presentation. Any comments from the panel before we go to Basem for the last one? And actually, someone is asking, Wissam, can you please explain the pre-mounted culotte? I think they got a little confused. You mind just for going through this for another few seconds?
Yeah, what I do, and I can go back in that presentation. So the idea here, I'll share the screen very quick. I know we're short on time. Sorry, I didn't mean to derail the conversation on prepping and things. So here what I do is I keep the cover of the stent. I just inflate very gently and quickly down to just expose the proximal strut. I pass the wire of the LAD here, and over that wire I advanced an NC balloon, usually 3.0 or 3.5 based on the size of the LAD, and then I crimp the stent again on it. Then I mount the stent over the wire of the circumflex, and both will be one unit that I advance together into the hemostatic valve, and I push both together over both wires up until they just reach that bifurcation. They just stop automatically. That tells me that the stent has reached its final place, and the balloon is ready to culotte. And so when you inflate both together, you're already in the second or third culotte step.
I love it. Essentially, you save yourself the trouble of rewiring, and then you know exactly where your access is there. So that's, as you say, it must save a lot of significant amount of time for doing the culotte technique. So excellent presentation. So can't wait to try it in live, as other people are in the webinar. And then last but not least, we'll go to Basem Elbarouni, who is going to talk about something we always don't want to see, but unfortunately we do see still. So complications for bifurcation and left main PCI. So Basem, thank you so much.
Yeah, thanks. I mean, my colleagues have presented their great successes and great outcomes. I get to share my failures and my worst moments. So thanks for choosing me to do that. But I think it's all important. I mean, any complication that can happen with PCI can happen with bifurcation, but there are three complications I want to focus on: side branch loss, perforation, which is a bit different in bifurcation lesions, and then hemodynamic compromises when you're dealing with left main. So this patient that comes in with the inferior STEMI has a left dominant circulation. The circumflex is successfully wired, flow is restored. The operator sees this tight lesion and decides, let's go ahead and stent it. But there's also an obtuse marginal coming off of it. A stent is deployed, and unfortunately that obtuse marginal is lost. I mean, we've all been there. This is not uncommon. There are predictors for side branch loss, pre-procedural side branch loss stenosis of more than 50%. The longer the side branch stenosis is, the higher the risk of side branch loss. Also, the pre-procedural proximal main vessel stenosis. If it's a true 1-1-1, the chances of occluding is higher. As I mentioned, the side branch lesion length. Acute coronary syndrome presentation seems to have a high risk of side branch loss, probably because of the presence of thrombus, and it seems to be in this paper. It seemed to be associated more with left main disease as well. Now, the cause of side branch loss, we always think about snow plowing the plaque, but it also might be related to the shape of the carina. If it has a protruding lip-like carina, that might be shifted with stents and causing the side branch to be occluded. So even in side branches that are relatively healthy, that could still happen, and we've all been there. So how can we prevent side branch loss? Well, there are a few techniques we could try. Wiring the side branch. So we always wire the side branch. The pros with that, if you put a wire down the side branch, it protects it. I'm not sure if it actually reduces the risk of side branch occlusion, but at least it acts as a marker. If you've lost the side branch from stenting the main vessel, at least you have a marker to where the side branch is. It might facilitate rewiring by keeping the side branch a bit more coaxial and more straight, especially if it has a more of a straight angle. It can act as an anchor wire. If you have a jailed wire that's behind a stent and you have difficulty delivering equipment, that might help anchoring your gear, improving your support. And in rare cases where you can't do anything, trying to deliver a balloon behind your main vessel stent to restore flow to the side branch might be used either with a microcatheter or a small deliverable balloon. Cons, of course, losing or damaging your side wires. And I've had one case where the side wire snapped off completely and had to stay in the vessel. Pre-dilating the side branch. So we've discussed this already, so I'm not going to dwell onto it. There are pros and cons. It might improve TIMI flow after main vessel stenting and prevent occlusion or side branch loss. It might make the wire crossing a little bit easier. However, it might cause dissections, increases your risk of crossing over, and does come with a higher risk of target vessel failure and restenosis. So I personally try and avoid it if unnecessary. There is anecdotal reports. Some operators like to use a cutting balloon for the side branch if they need to pre-dilate, more controlled dissection as opposed to just ballooning. I don't use this regularly. This is a case of a diffuse, challenging bifurcation, diffuse disease with a large diagonal. In this case, I was worried about losing the side branch, so I'd wired it and also pre-dilated it. But unfortunately, despite those efforts, I still lost that side branch, deployed the stent, and the diagonal had gone away. So what options could I have done here to try and prevent that? You might hear of the jailed balloon or highway technique. So when deploying the stent in the main vessel, have a wire in the side branch with the balloon over it. It's important to make sure that your balloon is long enough that the proximal marker or the proximal edge of the balloon would be proximal to your stent. Okay, you deploy your stent and then you have a balloon jailed in the side branch that helps keep the side branch open. There are two ways to do this. One is to leave the balloon not inflated, which is what I usually do. Make sure that your marker of the proximal marker of the balloon is proximal to the stent. Deploy your stent and take it off. If your side branch is patent, retract the balloon. If your balloon is jailed and not moving, you're able to inflate it to a low atmosphere to release it. If your side branch is occluded, then you can inflate the balloon and release the side branch, open up the side branch, and then remove your balloon as well. And then you do your final pod. Now, the other way to do this would be to have the balloon partially inflated to 3 to 4 atmospheres. What this does is that when you deploy your stent, your balloon gets squeezed and that contrast gets squeezed to the ostium. So it opens up the ostium, keeps it open, but without keeping your stent, allowing good opposition for your stent. And then once you do that, you remove your jailed balloon and then you do your pod proximally. I think this comes with the risk of ostial dissection, so I don't usually use that as a bit. The squeezing of the balloon is a bit uncontrolled. I use this technique usually in the next 3 to 4 cases where I've lost a side branch, and then it falls off the wagon. But it does work when I've done it. While preparing for this, I found a case report where instead of using a jailed balloon, they used a jailed microcatheter, a Corsair, and that managed to facilitate things. And then finally, the best way to prevent a side branch from being lost is doing a two-stent strategy up front. As Wissam mentioned, if you're really concerned about losing your side branch, this is a really challenging side branch with a long segment of disease. The angle is very challenging. So even wiring this might be challenging before you stent the main branch. Imagine doing that through side struts. So while the long-term outcomes might not be different either way in general, in this case, I'm extremely worried about losing the side branch, and I would start with a side branch stent first strategy, so which would be a crush technique or a culotte. Well, what if, despite your best efforts, you've lost your side branch? What are your options? Well, if you've got a jailed wire, you can use that jailed wire as a marker to try a wire into it. I usually would start with the workhorse wire and then try up-titrate high torque wires such as a Xi'an or a Versaturn. And if that doesn't work, use a hydrophilic wire. I think the Xi'an Black is a very good wire for this. The only downside is it's very difficult to shape. So take your time and patience to get the right shape on the wire. If that doesn't work, using a dual lumen catheter or a curved catheter, a pre-shaped one. I found anecdotally that sometimes a problem with trying to rewire the side branch is the proximal stent is not well sized. So pot first and then trying to rewire actually might help. And then if all else fails, maybe if you got a jailed wire, try to deliver equipment over the jailed wire. I found usually when I try this, it's hard to get the gear behind the stent, but it has been described. Now, if you manage to get into the vessel or the side branch architecture, but you're subintimal, then your bailout would be to do a star where you take a knuckle wire down until you enter the true lumen. At least you've restored flow and aborted a infarct, especially if it's a big size. If you don't have a jailed wire, then I would use the images still frame as a roadmap to try and find the ostium. Same wire techniques: high torque, hydrophilic wire, a dual lumen, curved catheter. Pot might help. Unfortunately, you don't have the option with the jailed wire, and it can be sometimes quite challenging. So in this case that I showed, after they stent the main branch using a Xi'an Black, we're able to find the side branch even though we didn't have a wire there. Luckily, we're able to salvage the side branch and restore flow. That's not always the case. So the second complication I'd like to discuss is perforation. Now, perforations happen in all coronaries, but in side branch, in bifurcations, there's always the risk of losing the side branch when you're trying to manage. So this perforation happened when we tried to get into the side branch, and after multiple trials, including we had to upgrade to a miracle wire. I have found some success with that, but unfortunately that led to a perforation. So now I had two complications in one: loss of a side branch and a perforation. I had to use the cover stent to seal the bifurcation, and the patient had to tolerate that the infarction from the side branch loss. This is a MEDINA 010 bifurcation. So we're hoping to do one stent strategy. This was IVUS guided. It seems that this is a common theme with perforation now that I'm seeing that we might be oversizing. So this was the Rota wire, the Rota Pro Drive, the new wire from Boston. It actually works as a workhorse wire. It was very easy to wire this. We did Rota ablation. IVUS guided PCI. Unfortunately, however, that did lead to a perforation in what looked like the ostium of the LAD. So now the challenging thing is if I'm using a covered stent, I risk losing the circumflex. So preventing this, image guided stenting, I guess, even though we use that here, and I find that debulking with atherectomy reduces your risk of using aggressive balloons to try and get better expansion. Management, long balloon inflation, maybe reverse the heparin, and try to land a covered stent distal or proximal to the side branch, depending on where you think the bifurcation is. And in some cases, the side branch loss might have to be accepted. In this case, I landed a covered stent just at the ostium of the LAD. You can see the circumflex now is looking like it's hanging by a thread, but it's got TIMI3 flow. I thought I had the perforation reasonably controlled there, but I don't think that was you know, I was being a bit optimistic. I didn't want to touch the circumflex at this point, so my plan was to bring her back to finish the job after this had sealed. Unfortunately, we did a bedside echo afterwards, and there was no effusion. But then 3 hours later, there's a large pericardial effusion requiring TAP. So what do we do now? Do we extend our covered stent, like we covered stent to the left main? With a jailed balloon, you know, even if you do that on your stored flow, you've still got not a fully expanded covered stent in the left main with the balloon behind that.
What stent was that? Was that a papyrus or was it a graft master that you put in there?
It was a papyrus.
Okay. So there's this fenestration. Sometimes people can penetrate the papyrus, right, and put the fenestration, but I mean, the stakes are high, and if it doesn't work, I mean, the circ is big, so I can see your dilemma there.
Yeah. So the options that if that is to just expand the covered stent and then hope that we can puncture back into the circumflex. If I was to do that, I'd probably put a DES into the circumflex first, just to make sure that the goal with the rewiring is large. The other option would be to do an SKS with covered stents. You know, it's long-term outcomes are not going to be great, but at least it salvages the procedure here. Now,
does anybody know what guide you need to do an SKS with cover stents?
Off the top of my head with papyrus, I would have to look it up, but I would guess it would have to be I would go with an 8 French.
Yeah, because I think I tried once with a 7 and it didn't work.
Didn't work, eh? Yeah, I would just go in with an 8 French if that's on my mind. But you know, you know, those are the options here.
Another option could be, especially if you, for any reason, you're doing the left main is a high risk PCI, you have an impella in, you can really afford probably to put a long cover stent in the left main, oppose it well, and then take your time to perforate the papyrus towards the circumflex, because you have the impella that is providing unloading and prevents a bit from a hemodynamic compromise up to a certain extent.
So you're saying put the you know, put the covered stent, seal, and then you've got time to try and puncture back in.
Yeah, I never did it myself, but I guess that if for any reason you already have the impella, you can afford the time to do that, because
yeah, that makes sense. That makes sense.
The other option is to call the surgeons, right? I mean, I know we don't want to call them, but you know, sometimes in life.
Yeah, I'm glad you said that, because you know, these cases, you know, stay with us. Did I make the right decision? And those are the options. And as I'd say, call a friend. This is also known as a surgeon, you know, especially at that point when you really need them. Luckily, I had a really good surgeon on call, and we discussed the options. The patient actually was, even though the bleed, you know, the patient wasn't doing very well at this point. The bleed was continuous. We had to transfuse her, you know, taking her back to the lab. You know, if I put a covered stent and lose the circumflex, I was worried that would just make things even worse, and I'll be dealing with 2 complications. So, so the surgeon took her to the OR, put grafts on, ligated, and controlled the bleed. And thankfully, she survived and was able to discharge from hospital. So that's what we ended up doing. But you know, sometimes you know, if you have a good surgeon that would step up, that was great. Hemodynamic compromise. So when you're stenting left main left main bifurcations, there's always risk of hemodynamic compromise. This is a patient with an ACS, had an ostial circumflex. There's moderate left main disease, but the FFR into the LAD was normal. So I decided that I would stent the left main into the circumflex with the wire down the LAD to protect it. This is the anatomy there. This is pre-dilated, then stented. And then at this point, the patient starts dropping his pressure. The LAD is completely occluded, despite what looked like a reasonably healthy ostial LAD. And then the patient went into PEA. So not a good place to be in. At this point, we started the patient on an ECMO. We were during the daytime. We managed to get the patient on ECMO very quickly. So now we are at least perfusing the organs. Now we have time to deal with this bifurcation. So it was extremely difficult to wire back into the LAD multiple wires were used. I tried to go around the stent with the balloon and microcatheter was unsuccessful. Eventually tried the Miracle Bro, and that actually got through. And I want you to notice that with the LAD occluded, there was a limited contractility, and you can see the aortic valve is completely blocked there. At this point, we're talking to the surgeons about potentially taking them to the OR while on ECMO. But then once we restored flow down the LAD, contractility starts coming back. And then now we switched to a culotte, did a final kiss, and had a reasonable result. And the patient did quite well. He was decannulated the next day with full neurologic recovery, except he couldn't remember coming to the cath lab or remember seeing me. So yeah. And he had a full LV systolic function recovered by time of discharge. So hemodynamic compromise when you're bifurcating left main, keep it in your mind. In some cases, upfront use of MCS is appropriate, especially if they have LV systolic dysfunction, prevention of side branch loss. Early on in my, when I was learning the DK crush technique, I would monitor the blood pressure. Blood pressure would be fine. Multiple stents, multiple balloons in the left main. And by the end of the procedure, the patient is in pulmonary edema. So I've learned to put a right heart cath so I can see that early on, see the pressures, the pulmonary pressure, the wedge pressure climbing, instead of being surprised by it at the end. Also, maintain short inflations, have your mix a bit more diluted so the balloon, when you deflate, comes down quicker when you're doing PCI in the left main. So left main and bifurcation stenting come with a unique set of complications. Anticipation, prevention, and management of such complications is an essential skill set to improve outcomes of these procedures. And I'd be happy to hear your thoughts.
Thank you. Thanks, Basem. That was a phenomenal. That was a tour de force on what can go wrong in bifurcation. So thanks again for sharing all those cases. Here's some questions that came up from the chat. One actually very creative question was, can you use the technique that Wissam described before, the pre-mounted culotte technique, maybe puncture the papyrus and do it this way, which sounds pretty ingenious if you ask me. So I don't know, Wissam, have you used that in that setting?
Thank God I have not had to, but I would if I had to.
Again, sounds ingenious, but again, it must be probably tough to actually inflate the papyrus, make a hole there. But I mean, and you know, it's a possibility. So if anyone does it, please let us know. I think that would be a good technique.
Yeah. I mean, the only issue with that is that you're, you know, the reason the perforation didn't seal, despite me landing the covered stent right at the osum, is that the perforation is probably a bit more proximal in the left main vessel. So you probably want your covered stent to be way more proximal, and the, you know, if you just lift the back of the strut to get a balloon into the circumflex, I'm not sure you're going to get enough coverage of where the perforation probably is. That technique, but it's
I think, yeah.
So when you have perforation at bifurcations, it's usually at the carana itself, so it's really hard to cover these. Maybe SKS stents or something like that. They're really very hard to deal with. So just having a stent that ends at the bifurcation is usually not going to be enough.
Yeah.
Yeah, but to be honest, I think, you know, we're going to be heroic sometimes, right? We want to be heroic and do crazy things sometimes and salvage it, which may work. But in a case like this, I think what you did was the right thing. You call the surgeon. If they take them, you know, they take care of the problem and things are going well. There was a question from the audience about what antiplatelets you had in that patient, and did the surgeon was okay with that?
That's a very good question. So I know the surgeon has taken patients that are on ticagrelor when they really needed to go. I can, and I think that's probably I'm not 100% sure, but I think this patient was actually on ticagrelor and the patient was taken to the OR. Lots of platelets, of course, and bleeding, but having a surgeon that's willing, you know, to do that was useful. You know, there is a reversal agent for ticagrelor that's currently being studied. Can't remember on the top of my head what its name, and we're not part of the study yet. We're getting the paperwork done, but I think if that would be a game changer in these type of situations.
Wonderful.
Can I have a comment? Sorry, go ahead.
Okay, so also recent data shows that you can also preload the patient at the end of the procedure. So maybe, or you can keep them on cannula during the procedure if it's a high-risk procedure, right? To prevent central thrombosis, and also in this case, you just turn the cannula off in case there is a perforation.
But Lorenzo, I want to argue the other way is that, in fact, in complex interventions, I would favor having preloaded a while back the patients with antiplatelets, because it's not infrequent that we give patients protamine at the end. And I want to feel comfortable that if we give protamine when the patient has enough antiplatelets on board. I know I don't have data to back me up, but in case like that, perforation, you take your gear out, you want to give protamine. You don't want things to clot if you don't have enough antiplatelets on board.
I'd also note that unfortunately in Canada, and Allison can corroborate this, Cangrelor is still not available.
Great. Well, again, I mean, in the interest of time, I know it's getting kind of late, so maybe each one gives a couple sentences. So starting with Allison.
Okay, so I think this has been an excellent session and lots of fantastic tips around both the planning, the execution, and management of the complications here. I think, it is, this last session on the complications is really key. As prepared as you are and as many of these techniques you apply, there are going to be complications, and I think knowing how to manage them effectively and knowing when to seek help, for instance, with surgical intervention, is really key. And also, to come back to Lorenzo's talk initially, making a careful decision that you're choosing the right technique up front and not overcomplicating things for a patient with, potentially limited benefit in certain circumstances. And if you are going with a more complex technique, just make sure you've chosen it appropriately and executed it to the best of your ability, I guess.
Wonderful. Wissam?
I want to thank you for this great night. We learned a lot. My advice is to just be patient with these cases. Take your time. A lot of planning ahead of time. Use IVUS all the time, and just a lot of these sessions like this one, just to learn what other people are doing.
Thank you so much, Lorenzo.
Yeah, my take-home message would be have a protocol, an algorithm to deal with each and every possible complication you might face, especially left main PCI, because you don't want to be inventing new techniques on the spot, figuring out what to do, and you need to have an algorithm and go through everything that can go wrong. So you just execute the algorithm once the problem arises. So having a plan is very important. Thank you.
And Basem?
Yeah, I'd just say thank you for inviting me to this. It's been a very educational session for me, and I hope you found the cases that I presented useful, and hopefully they'll help prevent or any further complications when you're dealing with these type of procedures. Unfortunately,
absolutely, they were wonderful. Thank you so much. Thanks, everyone. Would like to also thank Abbott, Boston Scientific, and Medtronic for their support of this webinar series. And again, a lot of learning today. Sorry for going a little bit over. Thanks, everyone, and hopefully see you in Denver in July 2022. Thank you so much.